This study looked at a data set of community urology practices and looking at patients in those practices that were diagnosed with de novo metastatic castration-sensitive prostate cancer. So essentially those patients that are showing up with metastatic disease. And then for those patients, there were sets that received either androgen deprivation therapy with apalutamide or ADT with enzalutamide. And then we were able to pull out what the PSA response was. So essentially, this was to look and see if we could see any differences between the depth and speed of which patients had a PSA response to their initial therapy with one of those two regimens. I think what we've started to see is with there's certain questions that we always want to answer that probably are never going to be able to be handled in clinical trials, right? People aren't often doing truly randomized prospective head-to-head trials with some of the multitude of options that we now have. So real-world evidence can provide a window into, if there are true differences or if there are answers to some of those questions that we might otherwise have. There's always going to be limitations with real world evidence, and I don't, think anyone should suggest that the level of data is equal to what we get in a prospective trial. But at the same time, that doesn't, that it's still very worthwhile endeavor to look and see what we can get. And I think especially in the era of medical records now being electronic and so many variables being able to be extracted in a discrete way or being able to be extrapolated from other data points that are in the that are able to be found, we really can get at some questions that before would have required such a real, both a laborious process of manual chart reviews, but also just that nature of doing manual reviews introduces different levels of bias and potential complications that I think when you're just taking a broad look at a big data set using electronic means, in some ways you are able to avoid some of that bias. So I think that more and more, both the quality of the data that's available and then the level of sophistication we have in doing some analyses, I think is allowing us to get some very interesting things out of real world evidence. The speed and the depth and frankly the reproducibility of seeing a PSA 90 response in these patients, and that once again that's a 90% reduction in PSA from pre-treatment levels, really appears to be different in this data set. And I think when we're as clinicians trying to make a decision on what treatments we're going to use, very often there aren't sort of the absolute differences that might make us choose one over the other based off of comorbid conditions or drug-drug interactions or some of the things that sometimes may drive a clinical decision. Very often we're left with, okay, we have a menu of options and what might we choose? So, in those situations, real-world evidence, I think, can be a help to be able to say to somebody, hey, to say to the patient or frankly to say as a clinician to oneself that, okay, there is this data that suggests maybe there's a more reliable PSA reduction. And what we do know from other data, from other evaluations and other trials also, is that achieving that PSA 90 more reliably and frankly earlier have long-term predictive, they predict long-term survival measures as well. So, that this isn't just an arbitrary number at an arbitrary time, but very specifically looking at the number of patients that achieve a PSA 90 at 6 months is an advanced marker for other survival measures that we, truly are what makes the difference for patients. So this study is very specifically looking at that early outcome of PSA 90. This is one of a series of evaluations we've done with either a similar data set or comparable data sets in medical oncology practices and others. This data set also is one of our first where we've been able to combine with some claims-based data in the same patient. So it's not just purely an extraction from the EMR. We're also matching it to claims-based data. And I think we'll continue with that approach to be able to get more long-term evidence out of this real-world data set, because that's not always apparent or easy to get out of electronic medical records, to know when there are other endpoints that may be met, like hospitalizations and even death and other things that may not be necessarily easy to see in an EMR. So yes, we are continuing to look towards long-term outcomes and measures to see if what we can learn from this data set. So right now, we don't have that patient level data to suggest that there might be a subset that is showing more benefit of one treatment over another. I think that is one of the limitations of real world evidence, is that we really are reliant on coding and some of the descriptors and not able to get to that true sort of, inside of an imaging report right now, to say, okay, do the patients have, metastases in one location versus another? And is that making a difference? Is there a certain volume of disease that might make a difference? And these are all very interesting questions, but ones that we just haven't been able to answer with real world evidence so far. I think one of the real important measures that came out of this study was that not just how quickly people were getting to a PSA 90, but overall, we saw that about 63% of patients with apalutamide got to that PSA 90 within 6 months, whereas that was right around 50% for the enzalutamide arm. So, I think that this kind of reliability or the, just being able to see more patients achieve that, and other studies that we've done have shown that difference seems to persist over the longer term if you follow those patients out further. I do think we've now seen this evidence play out over several different studies and several different data sets. So, the story it seems to be building at this point, that there may be true differences between these drugs, which is, exciting for patients if we can, start to really understand better how they're experiencing these treatments in the real world.